That's fine. So we'll kind of get started with the diabetes. The reason why I want to go into diabetes specifically is because diabetic patients, they don't typically, when you have diabetes, it's not one of the reasons you think like, oh, I have diabetes, I should go see a foot doctor. And this presentation is really just to kind of educate, just the public on why you should visit a podiatrist, routinely, yearly, every 3 months, depending on the progress of the diabetes. So this is just some background information. This just shows that, over the past like 30 years, the rate that diabetes has kind of increased over the past 30 years, it's kind of exponentially kind of increased, almost doubled. This chart, it kind of coincides with the next slide, but essentially the next slide should be first, but this graph essentially shows the number of discharges from non-traumatic low extremity amputations, which means discharges from infections, not anything trauma related. Okay. This is the graph that should have been first, but essentially it shows a graph of the amount of diabetic foot evaluations that now occur, now that patients are getting more and more educated on diabetes and feet. So now we're going to kind of get into kind of like the nit and gritty of some things that can happen with diabetes and the foot and ankle. So the first thing, and probably the most important thing that it affects, are the nerves. It can actually affect the nerves in many different ways, and we're going to kind of go over that very, very briefly. So diabetic polyneuropathy, or simply the medical doctors may just refer to it as neuropathy. It can kind of happen in 3 different ways, or it can affect 3 different types of nerves. It can affect the motor nerves. These are the nerves that cause your feet or toes to move. And it can cause, deficits to your sensory nerves. These are like the sensations that you feel, pain, things like that. And autonomic neuropathy. This is really the nerves that kind of maintain the balance of your foot, the moisture of your foot, the sweat of your feet, that type of thing. So they can all kind of be affected by diabetes. As the diabetes progresses and gets worse, it can really start to damage the nerves, causing these different types of things. Peripheral neuropathy is probably the most prevalent when it comes to diabetes. This pretty much means it affects the nerves that are kind of far away from the heart. As you further away you get from the heart, that's kind of like the periphery. So peripheral neuropathy is something that I test pretty much on every single diabetic patient that I see in the office. And we do it, very, very different ways. We use something called a monofilament. It's simply just like a fishing wire. Any normal person, they should be able to feel it if I poke them with that fishing wire. But as you develop neuropathy, patients start to lose their sensation. And it's very important to check and kind of educate them on just kind of being aware that they have loss of some sensation to their feet. So as I said, it can also affect the nerve or the motor nerves. So these are the nerves that kind of contract your toes and stuff. So because this can kind of happen, what can start to occur are something called hammer toes, or like digital deformities, bunions, hammer toes. And these are kind of important to note because as digits kind of contract, they can actually cause increase in pressure. And if you kind of think about that with the loss of sensation, if you kind of have this loss of pressure and you have increased pressure, this can lead to, calluses, wounds, and patients may not be aware that they have them. So it's very important that we kind of educate them on that. So this is kind of what I just discussed about the calluses. This is what's also referred to as the hyperkeratosis. So the more and more, if I were to kind of just take my finger and just slam this table repeatedly for the next like 30 minutes, I would develop almost like a sore on the tip of my finger, just from the repetitive trauma. And this is something that diabetic patients, if they have this neuropathy, they may not feel. So it's important that I kind of manage that for them, put them in diabetic shoes, give them inserts that are a little bit more like cushiony for them, so we can kind of decrease the amount of trauma they put across their feet. Something else that can happen is this plantar fat pad atrophy. We all have these nice natural cushions that we have on the bottom of our feet. When we walk, this kind of cushions are, the weight and the kind of impact that our foot places as we walk. With diabetes, one of the things that can happen is this plantar fat pad can, number one, it can atrophy or break down. And if you think about that, it's almost like you're just walking straight on your bones. instead of having that cushion by that fat pad. And the other thing that can happen is this fat pad can almost displace or move out of place. So it's not functioning as it's supposed to be functioning. Kind of going again on the kind of the musculoskeletal aspect. So as these tendons kind of contract and cause these hammer toes, this can really limit your range of motion. This is really, really important to kind of note because if you think about it, if we have these hammer toe contractions, your body's going to want to naturally kind of compensate for the lack of range of motion that you now get on your toes. But some other things that can happen is it can cause kind of decreased range of motion, which causes even more pressure that goes placed across your feet. This is kind of everything that we kind of discussed all in one graph: the fat pad, the limited range of motion, muscle weakness, and kind of like the toe deformities with the digital contractures. These can all kind of lead to the increased pressure, and this can increase your risk of developing wounds and ulcerations. Again, going back with the nerves a little bit, this is kind of like a repetitive slide, so I'll just kind of skip over it a little. So this slide actually goes over some of the testing that I send for patients. So an NCV, what that stands for is a nerve conduction velocity test. So essentially, if I'm concerned that my patient is starting to develop neuropathy, we want to kind of ensure that it's the diabetes that's causing it. But I will send them to almost like a pain management specialist or a neurologist to perform this test called an NCV. And what the NCV will show that from the velocity of the electricity that gets placed across your nerves, this actually decreases if you start to develop neuropathy. And with this test, the neurologist can really, kind of pinpoint where this nerve deficit is, if it's occurring from the back, if it's simply from neuropathy. So it's a very important test that I do. Another test that we can do, it's not very commonly used, is a nerve biopsy. So we can actually take a portion of the nerve and send it as a biopsy, and we can kind of see it. And I think a couple slides coming up, it'll kind of show you some pictures of some things that they can see from the biopsies. So some of the things that it can kind of cause, this neuropathy in specific, is it can start to demyelinate the nerves. Myelin is actually a component of the nerve that kind of surrounds the nerve. And this is what kind of allows that electric signal to kind of speedily kind of get through that nerve. And with neuropathy, this sheath kind of gets a little bit degraded and it kind of sends the signals much slower, or it won't send it at all. And like I told you guys before, this is some pictures. So these are some pictures of some nerve endings. And as you can see from A, this is almost like normal. And as we kind of get to C, you can see that, in terms of the brightness, the highlights, it's a lot less. And that kind of just shows you some of like the nerve damage that can occur with diabetes. This next slide is kind of referring to the myelin, that sheath that kind of allows that, that signal of electricity to kind of travel through the nerve. And as you can kind of go from A to D, you can see that the highlights kind of get less and less. And the less myelin you have, the less electric signals that can kind of get passed through the nerve. Autonomic neuropathy, like I kind of mentioned this a little bit earlier before. This is essentially, autonomic refers to almost like the balance of things. So when it comes to the feet, there's always a balance of moisture. It could be, the skin. If you develop autonomic neuropathy, you can get excessively dry or excessively sweaty. This can cause cracks in your skins, and also these can lead to wounds. Some other things that diabetes can cause is issues with your circulation. So as the blood sugars kind of get too high, they can cause damages to the vessels. You can kind of get these plaques if you kind of have diabetes with high cholesterol. Circulation is really important for me to kind of be aware of, because like I said, the most important thing for me for diabetic patients is I want to avoid wounds as much as possible. And the reason is because, diabetics, they have a high risk of getting infections, and they have a harder time healing these wounds if they get an infection. So circulation, if I will kind of check the pulses on my patient's feet and I don't really feel a pulse, I'll kind of routinely send them for circulation testing just to see if we can do anything to kind of improve their blood flow so they can heal a little bit better. So this is kind of just a picture of some of the deficits that can occur. This slide would actually be normal. You can see the vascular doctor has kind of shot a dye into the vessels, and that's why all of them are kind of popping up as black. In this picture here, you can see that, there's a lot less black, a lot less highlighting. And that's due to kind of the blockages in the vessels. And that will kind of tell me that the patient won't be able to heal a wound as well as, like a normal patient. This next slide that I have coming out next is a little bit graphic. It shows a picture of a wound. So if you guys are a little bit squeamish, maybe look away from this slide. But it just shows like a simple wound, a very common wound that I can deal with. So this right here, yeah, it's a little bit graphic. I apologize. But for me, when I see this wound, there's two reasons why, or three reasons why this wound is occurring. Number one, this area of the foot is a bony prominence. It's not, exactly where the toes are, but it's actually where the ball of the foot is. And this puts a lot of pressure on the foot. Another reason is this patient likely has a decreased circulation. So his, everything when it comes to the foot or anything in the body, we need blood to heal. Blood brings all the nutrients, all the oxygen to the wound, which will kind of allow patients to kind of heal the wound quicker. But because this patient has a little bit of a decreased circulation, he's not able to quickly heal this wound as like a normal patient would. Another thing is obviously the neuropathy component. If I had this wound on my foot, I would definitely feel it, and I would probably alter my gait to kind of avoid pressure on this area of the foot. Or I probably wouldn't walk on it, period, because I don't want to feel this pain. But because of this, the patient has neuropathy. He is consistently just walking on this wound. Whatever the body's trying to do to heal it, he's kind of breaking it all down by just walking on the wound again. So it's important for me to kind of, hopefully prevent this wound from getting down to the bone, because once it gets down to the bone, we really have two options. It's going to be really heavy antibiotics for an extended period of time, or just to purely remove the infected bone, which in other words leads to amputations. This is something I want to avoid as much as possible with my patients, because once we have, someone getting an amputation on one toe, they're at high risk for getting amputations on the other toes, and kind of leading to kind of like this partial foot amputation that you see on the bottom picture here. So this is kind of like that cycle that I kind of just explained with that ulceration that we saw on the top. They're all kind of linked. It's not just one reason that causes ulceration or the infection that the patient has. They're all linked, and I need to kind of assess and make sure that I'm kind of working up the patient properly so I can kind of heal the wound as quickly as I can so they don't lead to an amputation. So this next slide, it's going to talk about Charcot foot neuropathy. This is probably the most dangerous progression of the diabetes that patients can kind of end up with. And it's not just diabetic patients that get it, it's just patients that have this neuropathy or this nerve damage. There are many studies. We're trying to figure out why Charcot foot happens. Some people think it's just repetitive microtrauma. Some people think that it's, the bone is being washed out or it's getting weakened. But essentially what happens is, the next slide will kind of show you an x-ray, but essentially all the joints of the foot start to break down, and they'll kind of lead to what we call a rocker bottom foot. And if any of us were to walk on this type of foot, we would get that ulcer right here, this wound, because of the excess pressure. So Charcot foot, it purely occurs because patients are severely uncontrolled diabetics. Their sugars are in the 300-400s, their A1Cs are above 10. These patients are, I would call very, very sick patients, very unhealthy patients, and just not controlled diabetic patients. So I would say, the statistics have shown that about 16% of our diabetic patients have a neuropathic ulcer, and even less are kind of progressing to the Charcot foot. So this is kind of like that x-ray the x-ray of the foot. It's probably not the exact x-ray, but this is something that can happen with Charcot foot. Typically what we want to see is all these bones that you kind of see down here, they're actually supposed to be kind of up in this area, and you should see almost like a downward angle of the foot. But because the patient has this bony prominence here, their risk of developing a wound there is very, very high. So my job as a foot and ankle surgeon, if I see a foot like this, is number one, I want to make sure the wound is healed. And I want to make sure there's no infection. The next thing that I can do is I can actually kind of reconstruct the foot so we can kind of get rid of this bone and push it back up. This is done with plates and screws. All these stuff kind of stay in. But the goal for me is not to give this patient, a foot that they had before this all occurred. It's to give them a foot that they could walk on and not prevent wounds. So this slide just kind of talks about different stages of Charcot foot. I'll just kind of review it just kind of very briefly. Typically Charcot foot, it'll kind of start as a very, very swollen, red and hot foot. And a lot of things can cause this, blood clots can cause this. But when I have a diabetic patient come in and then I see like this red, hot and swollen foot, I absolutely have to rule out Charcot, because if it is Charcot, one of the most important things I need to do is completely immobilize this patient. Because if I don't immobilize them or put them in a cast and prevent them from walking, their foot will break down like that X-ray that you saw in the earlier slide. And that's the thing I want to try to avoid, because, if I don't have to put a patient through a very severe surgery, I want to do that at all costs. So if I can do that simply by just casting them for about 6 weeks, that would be a really, really good option for the patient. When it comes to the later stages of Charcot, what actually ends up happening is it starts as this very inflammatory phase, this red, hot, and swollen foot. The next stage is the joints will break down, the bones will break down. The next stage is after the breakdown is all calmed down, everything kind of solidifies in that state. So this X-ray that I kind of showed you guys before, once this patient is fully broken down, their bones will solidify and their foot will stay like this. Typically, when I do the surgeries, I want to wait for that phase for the bones to solidify, because I don't want to work with mushy bone or soft bone, because then the plates and screws won't be able to hold anything. This slide, it kind of just talks about, the contacts of the foot. With Charcot foot, you can see the contacts of the foot is much, much higher. So their risk of developing ulcerations is much higher than, the average person. This slide kind of talks about the different causes of Charcot foot. Some more X-rays for you about what we can potentially see in Charcot foot, just complete breakdown of the foot. Sometimes the bones even kind of disintegrate in this area. But again, this is the most dangerous thing. I would say, in my office, I don't see, I think I've seen maybe 3 or 4 Charcot patients like this year. And I see maybe like 35 to 40 patients a day. So, I think in terms of prevalence and patients that progress to this, I think the medical doctors, in the area, they manage the diabetes so well that, most of my patients will kind of end up on this. The patients that really show up with this are the ones that tell me they haven't seen a doctor in 10 years. They haven't been taking their medications. They really eat whatever they want. And they kind of develop to this stage. Okay. That's actually the end of the presentation. Does anyone have any questions about diabetes, foot and ankle problems in general that I can answer for you? Yep.
How often does a person who's 60 years old go to the podiatrist?
Sure. So typically when I see diabetic patients, number one, there's a couple reasons why they'll come back and see me. The first thing, and probably the most common thing, is diabetics, they tend to get fungus in their nails very, very commonly. So their nails get very, very thick. And if they have any like deformities, they get calluses. So some of the things that I do for patients is I do routine foot care, which means I will trim the nails for them and I will trim down the calluses, because I don't want them to get pain. I don't want them to get wounds. So typically, I would say it's most commonly that patients will come back every 3 months to have this done. If you're a well-controlled diabetic, you have no, hammer toes, no deformities, no thickened nails, no calluses, it's actually okay just to see a podiatrist probably once a year. But it's actually, I would say it's probably more important for this patient to probably come see a podiatrist, and they can really determine, you should really come back at said time, so I can kind of just check.
How about for a person who doesn't have that? Just for common street.
Yeah, that's a good question. I would say, as needed is not a bad thing. If you wanted just a general checkup, I think that's also a good thing. If you've never had x-rays, or we can kind of identify things. Obviously, I'm not trying to find something and, treat someone with it, if you have no issues with it. But, if for any general aches and pains, if you have even like knee pain, hip pain, one of the things that our practice does is we make custom orthotics or custom inserts. They can really kind of stabilize your gait, kind of correct the alignment of your leg, your hips, even your back. And that's something that, a lot of our patients come in and routinely come in for. Did you have another question over here, sir? No? Yeah, right. I was talking about the routine foot care earlier. Typically like insurance companies, they'll tell our diabetic patients to go see a podiatrist. But if you do have any sort of like, deformities, thickened nails, and there is a risk of, you not being able to cut the nails yourself, or if you cut the nails too short, you end up cutting yourself. I don't want that to happen either. So, if there's any issues, feel free to come see us. Sure.
But I just did something, some medication.
Yes.
But now the toe is kind of like a little bit, the nail is kind of half gone.
Yeah. So what he did was he actually used like he performed like an ingrown procedure on you. So he actually removed the ingrown nail and then he applied a chemical to prevent that portion of the nail from growing back. Yeah, correct. Yeah.
Should I see somebody about it? Because, the nail is kind of like
Half gone. Yeah. So, unfortunately, because he used that chemical, I would, pretty confidently say that this nail will not grow back. Your nail will not be the way it was before because he used the chemical. It should be something that he should have explained before he performed it, just in case you were unaware of it. But it's to kind of prevent, because the ingrowns, we can just simply take it out, but the risk of recurrence is actually pretty high. So even for me, when patients come in, I'll talk to them about both options. I can do it permanently, or I can do it, I could just take the ingrown out, and we can kind of cross our fingers and hope that it doesn't come back. So bunions, it tends to be a structural deformity, a bony deformity. And a lot of things can lead to bunions. It could be your foot type. If you're a little bit flat-footed, you can get a bunion. Or if you have, family history of bunions, the chance of you getting it is pretty high. Conservatively, there's not actually a whole lot that you can do for bunions. I can give you like this custom orthotic that I kind of talked about before. What that's supposed to do is supposed to kind of support your foot, because bunions tend to progress more when the foot is unstable. But in terms of treating it definitively, the only way to truly do that is with surgery.
What about tingling in the toes?
So tingling in the toes, it could be caused by a lot of different things. It can be caused by circulation. Simply tight shoes can cause it. And then the thing that I referred to before, neuropathy, can also cause it too. Diabetes tends to be the most common cause of neuropathy, but a lot of things can actually cause it. So yeah, if you have tingling in the toes, I think we should probably assess it. Yeah. Yeah. Any other questions?
Why does diabetes affect the feet so much?
Why does it affect the feet? So, diabetes, like I said, it's not a foot, disease. It's a whole body disease. But because diabetes kind of affects the nerves, the circulation, and the feet are something that, out of everything in our body gets the most pressure out of anywhere else in the body, this is where we kind of see a lot of like the effects of it. So the wounds, the infections, they tend to affect the feet first. And also the feet are not the cleanest part of our body too. We're putting it in shoes and socks. Sometimes some of us walk in barefoot. So they're more prone to getting infections. Any other questions?
And speaking about infection.
Yes. Yeah.
And like the treatment, is that, because I've read and it says that they can typically go away on its own.
Yeah.
But it can be a prolonged process. And I've actually had a situation, and I've gone to started at Bergen here, went to a dermatologist and a
Correct.
physiatrist. First it's a callus, just put it out. And after months of like what types of treatment, like permanent treatment?
Permanent treatments, yeah. So I think the thing with calluses and the most important thing that, I like to make sure that I don't do is have to treat a wart or, if it is a wart. Because the thing with warts is it's a viral infection and it gets into the foot and, the roots of the wart, they can get pretty deep into the layers of the foot. So simply, I like to see patients back routinely for it, actually. For us, we offer, I would say probably 3 treatments for warts in our office. We do almost like an acid treatment where we blister the wart. The second option is we can actually excise it, or in other words, cut it out in the office. And then the third option is to take it to the operating room and surgically excise it with almost like a bigger piece being taken out. And like I said, the most important thing is we don't want to half treat it. So if I'm seeing you back for the first option, the acid treatment, the acid almost kind of blisters away layers of the skin. So every time I see you back, I will shave the skin down and make sure I do not see any roots. If I see the roots, I have to kind of do another treatment. Essentially, treatment of warts, it always looks uglier before it looks better, because we're stripping so many layers of the skin away. We just want to make sure we get it all out before we let your skin kind of heal from the bottom up. Anything else? Anything from the?
Not from the chat so far.
Okay.
I want to say thank you to everyone for coming back today. Those of you who are here in person, please hang tight. We have a raffle to do, and I believe the hospital said you were getting the dietary screenings too afterwards.
Sure, yeah.
At the end time. But for those of you who joined us virtually, thank you so much for coming. I'm going to end the recording.